Hey, everybody. Fortunate to be joined here by Dr. Robert Riley, Director of Cath Lab at Overlake Medical Center. He's also the Director of Complex Coronary Therapeutics, as well as their Mechanical Circulatory Support and ECMO programs. He's here today to give us some information and talk about lithotripsy, and in particular in women, as well as his participation in the new EMPOWER study. Rob, thanks for joining us.
Yeah, thanks so much, Chris. I want to thank you and the team for having me out, and it's really a pleasure to get to join you guys and talk about some really fun stuff that's going on in interventional cardiology. So, in the spirit of Women's Heart Month, we thought that we would look at IVL use in the case and then talk about its use, particularly in women, and some of the big strides that are currently underway in order to further evaluate how we can continue to have better identification and treatment of women who have coronary artery disease. Case presentation, just real quick. 64-year-old female who came in with chest pain, elevated troponins, lateral ST depression, pretty classic non-STEMI presentation. She had had a right AX-FEM bypass due to an injury, so her right arm was a little iffy. A little bit of chronic renal insufficiency, hypertension, dyslipidemia. Initial echo showed a severely depressed EF with most of the wall motion abnormalities in the lateral distribution. Now, everything was moving, it just wasn't moving so good. A little bit more pronounced in that lateral distribution. And then a little bit of akinesis there in the apex, a little bit of moderate functional MR. So she goes for coronary angiography, as you can see here. You've got a pretty gnarly looking lesion there in the proximal circumflex that fits with those wall motion abnormalities. You can see as you come across to more of a spider view here, it creeps into that distal left main with some haziness. And then as you come to the cranial here, you can see a CTO of kind of that prox to mid LAD right there, right after that first septal with recannulation via left to left. Now, notably, you don't get recanalization of the entire LAD, so that's something just to kind of keep note of. As we continue to come around over to the LAO, you can see here a little bit of septal. And then here's the dominant RCA, no major disease, but does provide some right to lefts. Really the best are going to be over in our REOs, as you can see here. So you can see that there was the left to left to kind of the proximal aspect of the distal LAD, and then we really get the apical from those septal right to lefts there. So big heart team approach for this patient as they were pain-free at the time. CTS did not feel like the LAD could support a lima, which is honestly probably pretty reasonable. It wouldn't have backflowed anything. You would have had to do a jump graft at best. And so the plan was for a percutaneous approach. My partner was taking care of the patient at the time, fixed the circ. My only sort of request was that they not impinge on the left main so that I could fix the LAD subsequently if indicated, and then finish off the left main, just depending on sort of what IVA showed. They did get discharged and then showed viability in all of the segments by cardiac MRI just prior to their discharge. So they were kind of set up to see me as an outpatient. So once they came to see me as an outpatient, we kind of took a few weeks, got them on some meds, got their afterload reduction correct, beta blockers, all that stuff. We waited several more weeks, but unfortunately the patient just was still really with that lifestyle limiting dyspnea. We repeated their echo, their EF had improved some, but still was really severely down. So, this isn't really a BESIS revived patient because they were unfortunately still symptomatic, still with a low EF. And so at that point, seemed to be pretty indicated to go after that LAD, given that the RCA didn't have obstructive disease and the circ had been fixed. I felt like if we look back at those pictures that the proximal cap of the LAD, there may have been a little lead in, but when you have that much calcium, it's very hard to stay intraplaque. And I thought that the likelihood of retrograde was not small. And so I try to be pretty judicious about Impella use, especially Impella-assisted CTO PCI, one of the highest risk cases you can do in the cath lab. But in this case, relatively young patient, very symptomatic despite all medical therapy, EF still severely down, decent chance needed to go retrograde. So we decided on Impella-assisted LAD CTO PCI for this patient. So here's the setup shots. As we do our LAD CTO PCI, I do all my elective Impellas with general anesthesia, just from an access standpoint, makes things much easier. We have really great cardiac anesthesiologists here. As you can see, gosh, we do get reconstitution of most of that LAD, but if you'll remember on the cardiac MRI, that apex really was not very viable. And that makes sense, right? We really see really stringy, nasty filling of a heavily calcified LAD all the way through. And even if it was viable, the likelihood of really a good recanalization effort when it's that diseased all the way to the tips is really a challenge. You can continue to see that there is some ambiguity there. Maybe there's a little channel through. So we decided to start antegrade. But unfortunately, despite wire escalation, I just got lost. I mean, I was originally started with the Mongo Pilot 200, wire escalated up to Gaia 3 next, Hornet 14, could not get myself sorted. In this situation, you can often get yourself going with base to resolve that proximal ambiguity. There was a big septal bed, as you can see here, and there was some real concern about taking that out in somebody with a low EF. Could we have done it? Yes. Is it big enough for me to do side base? No, because the proximal cap's probably a little distal for that. So I decided to go retrograde, as you can kind of see here. Now, in this case, surfing septals ended up being a little challenging. So I ended up going through and actually doing selective injections in various parts of the PDA. You can do that with the septals as they come off. And then I like to do one at the very apex of the RCA. And in this case, you can actually see that it was a bit of an epicardial that's strung up here. Let me just see if I can play this again. You see here, and you really see it becomes epicardial here. And you know that because it's off the very apical part, and there's all this tortuosity based on the diameter. So it's probably running along the epicardial segment. That's only important because we surf septals and we wire epicardials. We don't surf epicardials for pretty obvious reasons there. I like to use SUO 03s for my epicardials because I believe that they're number one, they have the lowest grand tip, and two, SUO 03s, you kind of rock the wire back and forth and it often will find its way. It's a little bit more challenging in septals because it's so weak from a tip perspective in a body, but that's what I like to use. In this case, unfortunately, it was just a little too weak sauce to make all the navigation through this. Let me just play this again. Through this segment right here, I could kind of get the SUO to here-ish, but there's so much tortuosity here and you know, much like a telephone cord right through here. But the Xi'an Black was able to make it, which was really nice. We got ourselves to the distal cap. Corsair Pro XS 150 able to make its way through on up here. So in this section, in this situation, you know, we do kind of have a 20 millimeter or so. We also know where we're going because we have an antegrade marker. So I did wire escalate up to kind of a Pilot 200, and I was able to get my two areas here overlapped. But unfortunately, we got into a wire across gear wouldn't go because the distal cap was heavily calcified as well. And I worry about taking small balloons through really tortuous epicardials like that. Whether I should or I shouldn't is another debate. But it did help me resolve my ambiguity here with my antegrade gear. So then I could get things overlapped. I was able to take an antegrade balloon that distal cap, which allowed me to then get my my retrograde microcatheter across the area where I had wire across but couldn't get the MC to go. I then set up for traditional reverse cart with my guide extension in here, able to cross with a Gladius wire in. Now, I will say after externalization with an R350 wire, the patient did not love that. Even with the impel in place, they got pretty hypotensive, just did not like me being across that entire abdominal RCA over. So in that case, that's usually where we use a quick 2.0 balloon to dilate the tract, Sasuke dual lumen microcatheter down, workhorse wire here, take my retrograde situation out. And then I always, before I get my microcatheter back too much, I take shots retrograde to make sure that there's no perf there before I take everything too far back so that I have access.
And for all our
go
viewers,
ahead. Yeah.
Rob, you know, essentially what you did there is almost an external cap crush on that distal cap, but via your antegrade system, and it facilitated your reverse cart. Did you have to balloon escalate, or were you able to just use that one balloon and did everything for you? Got your gear across retrograde and allowed you to make that reverse cart work, or do you got to keep upsizing balloons there?
Yeah, I was probably intraplaque, which is why things were so difficult. Usually intraplaque is where the real difficulty is there. So it's a little bit of a modification on an external cap crush. But yeah, it was actually just a 2.0 to carry you, which is kind of my balloon of choice with these really tight situations, particularly in CTOs. That 2.0 is actually able to expand to give me just enough room for my retrograde microcatheter to get up. And then I was able to wire into the guide extension, get the microcatheter to follow, and then externalize with my R350.
So you might have been plaque to plaque both ways.
decent chance I was plaque. Well, I was probably intraplaque retrograde, and it did not look on intravascular imaging I was ever extra plaque. So yeah, I was probably plaque to plaque. I just couldn't get myself sorted antegrade because of all the calcium and ambiguity on the cap. So I really had to use that retrograde system to, I had to use it to really solve that situation. You know, there are people very skilled with intravascular imaging who maybe could have brought something down. The problem was that if that septal had been closer to the cap, I could have either done side base, or actually the septal was big enough to bring IVUS into and maybe see that proximal cap, but there was probably 4 millimeter gap between the septal and the proximal cap. And so that wouldn't have worked. And so and again, base is a great way to resolve proximal cap ambiguity, especially in calcified lesions. But again, whether I should have worried about it or not, it's a very big proximal septal bed, and I didn't want to risk that with base.
I think this is a really elegant way to solve your ambiguity, and you got all your equipment across. I mean, you can't really argue with this.
Then what we do is we do repeated small balloons, and that really because you don't know where you are. You think you know where you are, but you really don't know where you are until you bring your IVUS in. You can even be fooled with workhorse wires and all of that. And so I try to be gentle enough to where I'm not going to wreck anything too bad if I'm extra plaque and smears, but obviously big enough to where you can actually get your IVUS catheter in. So after that 2.0 goes in, we bring our Boston HT in. And what we actually see is distally, we've got some eccentric calcium, but really proximally, I cut the IVUS pretty short just because 100 millimeters of IVUS is a bit boring to go through. But we see some very heavy, thick, concentric calcium. So we meet the criteria of ARC of 270 or greater. We meet the criteria of greater than 5 millimeters, and we meet the criteria of thickness of greater than 0.5, all of which you can see with IVUS. What you'll actually notice here is you'll actually lose the IVUS for a second, and a lot of people are like, oh, you needed to flush, and it's actually more than that. So when this HT IVUS, because it's rotational, goes through a really tight segment, you actually will lose, because when it's rotating in that very tight segment, it generates a little bit of air and you get a bubble. So that often actually just means you're through a really tight spot right there that actually just popped up. Yeah. And you'll notice right after I flush, it's tight as a drum right around that IVUS catheter. So we know we're pretty tight there. So we had all the criteria for calcium modification in this patient. Now, the question is then, what do you use? Well, if you think you're going to get a specialty balloon down there and modify 40 millimeters of calcium with that, good on you. I'm not sure that that's 100% rational, especially given that the only data showing to do it is to go up with, from the COP study, a Wolverine balloon up to, 18 atmospheres, and doing that over 40 millimeters in a patient who already showed me they got sick once is probably not my cup of tea. Then you got to ask yourself, could we do rotational atherectomy here? And yeah, you sure could. It's a long diffuse segment there. Some people would polish that up to make the procedure more efficient. Again, you certainly could. What we also know is that we've got an area mid to distal LAD that does not need significant calcium modification outside of an NC based on what we saw. And we are able to, with pretty good guide support, get our intravascular lithotripsy in. Despite Impella support, the patient had already shown that their LV was not super happy. They were able to get sick. And so intravascular lithotripsy is probably the safest from a complication standpoint and from a needing more stuff, right? Because just because we do rotational atherectomy doesn't mean we'll get fractures through, because we're not modifying anything. And so that's where IVL can really be the winner here, because it gets everything that I need. I can get the calcium modified with very low risk of major adverse events. So that's what we did. We took a 3.5 IVL through there. All the way back. We did NC balloons distally, that IVL proximally, and this is what we get. Now, and again, we were not expecting to get the cap, because unfortunately that area was no longer alive. I did end up doing a late DK mini crush of my partner's circumflex stent.
Yeah, I mean, you got 100 septals and 100 diagonals there, so I mean, you can't ask for a better result, man.
Yeah. So we were able to wean the Impella off of this patient, extubate them, and then I send these people home same day. Just COVID taught us that we can do a lot, and even with anesthesia and Impella, these people do really well and can get out of there. So just a little bit of context. Oh, go ahead.
How long do you wait? How long do you watch them? You give them that 6 hours before they leave? You give them 8 hours? What do you do with them?
Yeah. Good question. So obviously I spend a lot of time with them in the cath lab. And then as soon as I'm done, now in this case, I did not start weaning until the very end because I had a left main to do after the LAD and a bifurcation. And again, the person had already shown me that they're able to get sick. If this person had been rock solid even when I was retrograde, maybe different. But in this person, I really didn't start to wean until I was done. And so I used to wait longer. Now I'm waiting 5 minutes, turning down a couple P levels, 5 minutes. And I'm rechecking PA sats for fix. I'm looking at their PAPI in general, just their pulsatility, and their PA, and then obviously looking at their AO pulsatility and just sort of making sure that we're not too far off baseline, realizing that their SVR is going to be a little down from general anesthesia and stuff like that. But
and how long do you watch them post procedure?
Post-procedure?
After it all works out for you, then Petla's out, everything's closed up, shop's closed up. How long do we watch them in the post-op area before we get a send?
All our FEMs stay for 6 hours anyway, and so this is the same. So they'll get 6 hours, and our post-procedural unit will stay open until 10 or 11, so it works itself out pretty well. People kind of want to get out, and honestly, with sick patients like this, as long as they're stable, it's better to get them out.
Yep.
A little bit of background on why I think cases like this and in general IVL sort of are really important for this. In the spirit of it being Women's Heart Month, for decades and decades, historically, women are underdiagnosed, undertreated, and underrepresented in clinical trials. This, I think, is thankfully now kind of a known entity. When we look specifically at coronary arterial calcification, it's an independent predictor in men and women, but more so in women for major adverse events in the peri-procedural period. They also have worse outcomes when you use traditional calcium modification devices, such as atherectomy. I mean, much, much worse compared to their male counterparts. There's a lot of hypotheses for why that is, but much, much worse. In terms of specialty balloons, who knows, because there's no data. And that's really a challenge, right? We have women who traditionally they're underdiagnosed. When they are diagnosed, they do worse. When they have calcified lesions, they do even worse, even when we use these traditional tools. And so women just generally do worse, and when you're kind of stuck, right? But what's interesting is we do the Disrupt CAD3 study, and then we put that together with the kind of pooled analyses, Disrupt 1, 2, 3, and 4. And that's a pretty decent sample size right there. And so what you can do is, you can retrospectively look at gender analyses to see if there's a big differential when you sub-select for gender. And when we look at the outcomes based on gender, we see no difference in procedural success. And that is not a small thing, given that women have traditionally worse outcomes, both from a procedural standpoint and a major adverse standpoint. And we see no difference in either of those outcomes when we look at men versus women. And again, we haven't seen this before. We haven't seen data like this. Now, it's retrospective. This is what I consider to be hypothesis generating, but really important, even when we extrapolate out to the 30 days, the 2 year, especially with the complications. And this is really, really key. Women not only have more complications, but they do worse with complications compared to men. And so if we have a technology that can mitigate that in a procedure that's already at higher risk, that's actually something to really think about, right? So Shockwave sees this, again, sees, hey, hypothesis generating, let's look at this prospectively. And that's where this EMPOWER CAD study came through. A couple of my friends who are the national PIs, specifically Margaret McIntaggart, and I think really, really excited to see what this looks like. Already enrolling, getting halfway through it at Overlake. We're lucky to be a part of this study as well. It's really just looking at routine use of IVL in women. So this is going to be women who would have already gotten IVL, but specifically calling them out to look and say, let's follow these women prospectively and see what their outcomes are. This is the treatment algorithm. It's going to be very similar to routine clinical practice. The IVL will pass yes or no. If so, we follow them and use it. If not, you can use adjunctive therapy. If you still need to use IVL, obviously they're enrolled and continuing to look at them. As you can see here, again, enrollment's already started. Really excited to see when we close that up and see what the results are. So in conclusion, these calcified coronary lesions are increasing in prevalence in men and women, but specifically women has worse outcomes when we treat them with these heavily calcified lesions, even when we use traditional calcium modification therapies. IVL has been shown to be a potential bridge to this gender gap in treating these lesions in some retrospective analyses. And there's now a prospective study, that EMPOWER study, that's enrolling to evaluate this hypothesis further. So really, really excited to see that we're finally focusing on an underrepresented population that's typically got worse outcomes, and finally trying to figure out how do we bridge the gap for women. And again, we haven't seen that much, and I hope that this is the start of more studies looking at this.
Yeah, completely agree. I think this is really important. I mean, this is one of the first times, at least in my career, that somebody or a large company has been able to directly, address a entirely undertreated group of people explicitly for the purposes of, making a therapy for them. So I think that was an awesome talk and an awesome way to wrap up Women's Heart Month. And as always, I learned several things. So thank you again for doing that for us. And that was a wild and awesome case. And proves that you don't necessarily need any of the adjunctive therapies except for a nice lithotripsy balloon, no matter how much calcium you see. So that was awesome. Thank you, Rob.
I really appreciate it. Again, just want to thank you and the entire team for having me on, and just, yeah, excited to see this technology continue to move forward. Excited to learn with you guys moving forward, and looking forward to seeing more of this on the channel.
Sure. Thanks, man. Bye.
Take care.